Same pill, same dose, same prescription, different time. That is the only variable I want you to think about for the next few minutes. Not a new medication, not a different diagnosis, not a lifestyle overhaul, just the time on the clock when a tablet that is already sitting in your pill organizer gets swallowed. Because what I am about to tell you is that for many seniors on amlodipine, that single variable, morning versus night, may be making the difference between a medication that is fully protecting the heart, the brain, and the kidneys during the most dangerous hours of the day, and one that is doing most of its work during the hours when the body needs it least. I am Dr. Eleanor Bennett. Subscribe to this channel before we continue, because this video is one of the most specific, most practical, and most actionable conversations I have on this channel. No dramatic diagnosis, no frightening new side effect, just a timing question that most seniors have never been asked, and whose answer may be worth more than any dose adjustment their doctor has ever made. Let me start with the fact that surprises almost every patient who hears it for the first time. Your blood pressure does not stay the same while you sleep. Most people assume sleep is a period of cardiovascular rest, the heart beating quietly, the pressure low and stable, the system at peace. And for many people that is partially true. Blood pressure does drop during sleep in most healthy adults. This drop, called nocturnal dipping, is a normal and protective phenomenon. The cardiovascular system gets a genuine rest. The heart works less hard. The vessels experience less mechanical stress. But in seniors over 60, this pattern is frequently disrupted. Arteries that have stiffened with age respond differently to the hormonal rhythms that govern nocturnal dipping. Sleep disorders, which become significantly more common after 60, interrupt the pressure patterns that depend on unbroken restorative sleep. Conditions like sleep apnea, which is dramatically underdiagnosed in older adults, cause repeated microarousals during the night that spike blood pressure repeatedly without the person ever fully waking. And in some seniors, blood pressure does not dip at night at all, a pattern called non-dipping, which is associated with significantly higher risk of heart attack, stroke, kidney damage, and cognitive decline compared to seniors whose pressure follows the normal nocturnal pattern. And then there is the surge, the morning surge. In the hours before and just after waking, roughly from 5 in the morning until noon, blood pressure rises sharply in most adults as the body prepares for the demands of the day. Stress hormones flood the system. The nervous system transitions from rest to active regulation. The heart increases its output. The vessels tighten. And blood pressure climbs, sometimes dramatically, in a window that also happens to be the period of highest risk for cardiovascular events, strokes, heart attacks, dangerous arrhythmias. These events cluster in the morning hours not by coincidence, but because the cardiovascular system is under its greatest daily stress in exactly that window. Now here is the question that this video is built around. If you take your amlodipine in the morning, at 7, at 8, at 9, when does it reach its peak effect in the blood? The answer, for most formulations of amlodipine, is 6 to 12 hours after ingestion. That means a 7 a.m. dose reaches its maximum blood pressure lowering effect sometime between 1 and 7 in the afternoon. The hours when most seniors are sitting quietly, reading, watching television, eating lunch, the hours of lowest cardiovascular stress, the hours when the body needs the most help least, and where is the medication's effect at its weakest? In the late night and early morning hours, exactly the window when non-dipping occurs, when sleep apnea spikes pressure repeatedly, and when the morning surge arrives. The hours of greatest cardiovascular risk, the hours the medication is covering least effectively when taken in the morning. This is the 8-hour window, and for a meaningful subset of seniors on amlodipine, it represents the gap between a medication that is working and a medication that is being wasted on the wrong hours. Let me tell you about Alice. Alice was 69, organized, compliant, and genuinely puzzled. She had been on amlodipine for 4 years. Her afternoon readings at home were consistently excellent. Her morning readings, taken within the first hour of waking, were regularly higher than her doctor wanted them to be, and no dose adjustment had resolved the pattern. Her doctor had discussed increasing the dose twice. Both times Alice had hesitated, worried about more side effects, and both times the discussion had ended without the one question that would have changed everything. "What time do you take your amlodipine?" 7 in the morning, Alice said. "Always. I set an alarm." Nobody had ever asked. Nobody had ever connected her excellent afternoon readings, her elevated morning readings, and the pharmacokinetics of a medication whose peak effect arrives 6 to 12 hours after ingestion. The picture, once assembled, was clear. Alice was taking her medication at 7 a.m. It was peaking at 1 to 7 p.m., her best readings of the day. It was at its weakest at 5 to 7 a.m., her worst readings of the day. She was, with perfect discipline and perfect compliance, optimizing her medication for the wrong hours. Her prescriber moved her dose to 9 p.m. Within 3 weeks, her morning readings had improved more significantly than any dose adjustment had achieved in 4 years. The medication was the same. The dose was the same. The timing was different, and the body it was operating in had been given coverage during the hours it most needed it. Now let me be precise about what the research tells us, because this is not a fringe theory. There is a growing body of evidence in cardiovascular medicine suggesting that bedtime dosing of blood pressure medication, what researchers call chronotherapy, can produce meaningful improvements in blood pressure control, particularly in the nighttime and early morning hours, and may be associated with better long-term cardiovascular outcomes compared to morning dosing. Research following thousands of patients over several years found that those who took at least one blood pressure medication at bedtime had significantly lower rates of cardiovascular events, including heart attack and stroke, compared to those who took all medications in the morning. The nighttime group also showed better nocturnal blood pressure control and a higher rate of normal dipping patterns. These findings should be reshaping prescribing conversations, and in many practices, they have not yet reached the patient sitting in the waiting room. This does not mean everyone on amlodipine should switch to nighttime dosing. The right timing depends on the individual, and that is precisely the conversation this video is designed to prompt. Before I tell you who benefits most from nighttime dosing, let me tell you what non-dipping actually does to the organs over time. Because understanding the damage makes the timing decision feel less academic and more urgent. The kidneys, like the heart, depend on the overnight period as a time of reduced workload. When nocturnal blood pressure dips normally, the kidneys' filtering structures experience lower mechanical stress for 6 to 8 hours every night. That rest is not optional. It is part of the kidney's natural maintenance cycle. When a senior is a non-dipper, when the pressure stays elevated throughout the night, those filtering structures never get their rest. The continuous pressure exposure accelerates the same kind of microscopic damage that daytime hypertension causes, but it does so during hours that nobody is monitoring, measuring, or treating. Research consistently shows that non-dippers have higher rates of kidney function decline, higher rates of proteinuria, protein leaking into the urine, a marker of kidney stress, and higher rates of cardiovascular events than dippers with the same daytime blood pressure readings. 2 seniors with identical office readings can have completely different organ outcomes depending entirely on what their pressure does at night. and the one with the worst outcome may be the one whose medication was calibrated only to the afternoon office visit. The brain tells a similar story. Cerebral small vessel disease, the quiet accumulation of damage to the tiny blood vessels that supply the brain's white matter, is strongly associated with sustained nocturnal hypertension. This is the kind of damage that does not announce itself as a stroke. It accumulates invisibly, contributing over years to slower thinking, less reliable memory, and the kind of cognitive decline that gets called age, when it might more accurately be called unmonitored overnight blood pressure. Rebecca was 71 and had been told her blood pressure was well managed for 5 years. Her office readings were good. Her home readings in the afternoon were good. But she had been experiencing what her family described as gradual mental slowing over the past 2 years. Nothing dramatic, just a sense that she was not quite as quick as she used to be, not quite as sharp in conversation. When a 24-hour ambulatory blood pressure monitor was finally placed, her overnight readings were consistently elevated. She was a non-dipper. Her medication, taken every morning, was providing excellent afternoon coverage and almost no overnight coverage. The gap in her treatment was the gap in her cognitive health. Addressing her overnight blood pressure pattern became, for the first time, a treatment priority rather than an afterthought. Let me tell you who benefits most from nighttime amlodipine dosing, and who may be better served by staying with morning. Seniors who are non-dippers, whose blood pressure does not fall adequately during sleep, represent the group with perhaps the most to gain from nighttime dosing. Nighttime medication places the peak effect exactly where the pressure is staying dangerously elevated instead of resting. The medication is not wasted on the afternoon hours when the body is already managing reasonably well. It arrives at night when the failure to dip is doing its quiet damage to the heart, the kidneys, and the brain. Seniors with elevated morning readings that have not been resolved by dose adjustments, like Alice, represent another strong candidate group. If the morning surge is the clinical problem, having the medication peak during the nighttime and early morning hours directly addresses the source of the reading pattern, rather than chasing it with higher doses that increase side effect risk throughout the entire day. Seniors with a history of nighttime cardiovascular events, atrial fibrillation episodes that tend to occur in the early morning, angina that wakes them, or a prior heart attack that occurred in the morning hours, represent a group in whom the timing question deserves particularly careful, individualized attention. On the other side, there are seniors for whom morning dosing makes more practical and clinical sense. Seniors with a significant morning dip, whose blood pressure is actually lowest in the first hours after waking, who feel dizzy or weak upon standing in the morning, are at risk of having that dip pushed further by nighttime medication that peaks in the same window. For them, morning dosing spreads the medication's effect through the afternoon and reduces the risk of compounding an already low morning pressure. Seniors who are prone to falls at night, who get up to use the bathroom, who move through darkened rooms, who have balance concerns, need to be cautious about a medication whose peak effect occurs during those nocturnal movements. A blood pressure that drops during a 3 a.m. bathroom trip is not an abstract risk. It is a fall risk, a fracture risk, and the timing decision must account for the real physical environment of that person's nights. And seniors with complex medication regimens, where multiple drugs are already being timed to specific windows for specific reasons, may need a more deliberate and supervised approach to any timing change than a simple switch. This is why the conversation matters more than the conclusion. There is no universal right answer to morning versus night. There is a right answer for each individual person, one that depends on their blood pressure pattern across 24 hours, their sleep quality, their fall risk, their cardiovascular history, and the specific way their body has been responding to a medication it may have been taking at the wrong time for years. Let me tell you about George. George was 74, had been on amlodipine for 6 years, and had never experienced a memorable problem. His readings were acceptable. His doctor was not alarmed. He had no obvious symptoms to report. But George had been told by his wife, with increasing frequency, that he was a restless sleeper. She had begun sleeping in the spare room because of it. His family doctor, at a routine visit, asked about sleep quality. George mentioned the restlessness. A sleep study was recommended. The results showed moderate obstructive sleep apnea, a condition that had likely been present for years, causing repeated nighttime blood pressure spikes that nobody had been measuring because nobody had been looking. George's blood pressure was managed adequately during the day. At night, while he stopped breathing repeatedly, his pressure was surging in a way his daytime readings had never revealed, and his medication, taken every morning, was doing almost nothing to address. His amlodipine was peaking in the early afternoon while the damage was being done at 2 a.m. His treatment plan changed. He received a CPAP device for the sleep apnea. His amlodipine timing was reviewed, and for the first time in 6 years, his overnight blood pressure pattern was evaluated directly with a 24-hour ambulatory monitor that showed what his home readings had been hiding all along. George said afterward that he had felt vaguely tired for years in a way he had attributed entirely to age. Within 2 months of treating his sleep apnea and addressing his overnight blood pressure coverage, the tiredness changed in a way he had not expected. Not dramatically, but noticeably, as though something that had been quietly draining him had finally been turned off. So what should you actually do with this information? The first step is not to switch your amlodipine to nighttime on your own. I want to be completely clear about that. A timing change for blood pressure medication requires a proper conversation with your prescriber, ideally accompanied by a record of your blood pressure readings at different times of day, morning, afternoon, and if possible, immediately upon waking before any medication. The second step is to ask your doctor a specific question, not, "Should I take my amlodipine at night?" which can seem like you are challenging their prescription. But rather, has my blood pressure pattern ever been evaluated across the full 24 hours? And is my current dosing time matched to when my pressure is most elevated? That question opens a conversation. It signals that you understand the timing matters, and it gives your prescriber the opening to consider whether a review is warranted. The third step is to know your morning readings specifically. If you monitor at home, start tracking not just a general morning reading, but a reading taken immediately upon waking, before getting up, before coffee, before your medication. That reading, compared to your readings at other times of day, tells the story of your overnight blood pressure pattern in a way that a single afternoon office visit never can. There is also a tool that most seniors on blood pressure medication have never been offered, and that provides more information about actual blood pressure control than years of office visits. It is called ambulatory blood pressure monitoring, a small wearable device that measures blood pressure automatically every 15 to 30 minutes throughout an entire 24-hour period, including during sleep. The result is not a single number taken in a quiet examination room after 5 minutes of rest. It is a map of the pressure landscape across an entire day and night, showing peaks, troughs, the overnight dip or its absence, the morning surge, and how the medication is performing across every hour rather than just the hour of the appointment. This monitoring is available, it is not uncomfortable, and it is the only way to know with certainty whether a medication is providing coverage when and where the body most needs it. For any senior whose morning readings are consistently worse than afternoon readings, whose daytime control seems good, but whose cardiovascular risk profile suggests something is being missed, or whose sleep has been questioned by a partner or a doctor, a 24-hour ambulatory blood pressure study is worth requesting by name. It is the difference between looking at a single photograph of the weather and watching a full day's recording. The photograph may show sunshine. The recording shows whether there was a storm at 3 a.m. And the fourth step is to mention sleep. If you snore, if you wake repeatedly, if your partner has noticed interrupted breathing, if you feel unrested despite adequate hours in bed, say so. Sleep apnea and blood pressure medication timing are not separate conversations. They are the same conversation about what happens to your cardiovascular system in the hours when nobody is watching. Alice did not need a higher dose. She needed a different hour. George did not need more medication. He needed his existing medication to be matched to the problem it was supposed to be solving. And both of them, once that matching happened, experienced something that years of dose adjustments had never delivered. Not a dramatic transformation. A quiet, consistent stabilization of the thing that had been unstable for years. The kind of change that happens when a medication finally starts working during the hours it was always needed most. Same pill, same dose, different time, completely different story. Share this with someone who has been adjusting their amlodipine dose without anyone ever asking when they take it. Subscribe to this channel, and I will see you in the next video.